This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
Use them as that front door. We're ideally getting to the patient to the right stop faster than we would if they had to wait weeks and weeks to see a surgeon and then find out that they're not even remotely appropriate for that. And these days, a lot of payers won't even allow this anyway. Many are requiring at least several weeks of physical therapy before you can do practically anything else these days. A number of reasons why we think physical therapy should be at the start more intentionally of that back pain journey, and probably a lot of other things as well.
Welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. Today we're talking outpatient rehab, a place where there's significant growth. There's plenty of barriers and creative workforce options. And it's a place where we're seeing systems invest because we're learning what a valuable piece of the patient's relational care journey PT and OT can be. We have Donnelle Jageman, who leads our orthopedics team, and Kate Zentner, who leads our neuro team, to talk about this exciting, growing space. Thank you so much. Donnelle, you're first. Start by defining what we're talking about when Sg2 talks outpatient rehab. What's included?
Thanks, Trevor. When we talk about outpatient rehab, we are primarily looking at orthopedics and spine as the service lines. Combined, orthopedics and spine make up about 80% of rehab volumes every year in our forecast, which is a huge majority. And then it sharply declines after that. Neurosciences makes up about 8%, and then we get into even further single digits as we go. We really concentrate on the programs around ortho and spine when we're looking at outpatient rehab, whether it's physical therapy, occupational therapy, or chiropractors.
That's helpful. Thanks. Kate, talk workforce. My understanding is there's some pretty flexible options and models here. Workforce is still a constraint, but maybe not as much as other growth areas. Before we really talk about what's growing and why, and even though there's some growth, there's still plenty of barriers.
Sure, Trevor. Whenever we are discussing how to extend access with all the constraints that we're facing, interdisciplinary teams is the first thing that comes up. Physical therapy and rehab in general, we believe, has a huge role to play in that, both in terms of just comprehensive clinical care, but also how can we get faster access with a broader team that can do some of these different roles. Two main things that I would want to talk about here. The first is that we've seen physical therapy as another option to act as the front door for services. For example, we've heard of some organizations using physical therapy to do an initial red flag exam for that back pain patient and embedding them in strategically selected sites like urgent care or wherever they're presenting first. This way, they can even start to see patients and begin them in treatment same day if it's needed, which if you think about back pain, about 85% of people, they're not going to need anything more than rehab. If we use them as that front door, we're ideally getting to the patient to the right stop faster than we would if they had to wait weeks and weeks to see a surgeon and then find out that they're not even remotely appropriate for that. These days, a lot of payers won't even allow this anyway. Many are requiring at least several weeks of physical therapy before you can do practically anything else these days. A number of reasons why we think physical therapy should be at the start more intentionally of that back pain journey, and probably a lot of other things as well. That's one side of it. When we're thinking front door to a program, the other piece that we should acknowledge, particularly for spine, is chiropractors. In a lot of markets, a lot of cases, we find that whether it's formally part of your program or not, that is where a lot of patients will go first. We have seen some spine programs starting to think through how they can incorporate that as well.
We're also seeing that shift into more traditional orthopedic programs where instead of a patient going directly to a surgeon, they're actually getting the referral to the surgeon from their physical therapist. And that referral dynamic can be really important depending on whether or not your physical therapists in your market are closely aligned or not with your health system.
Donnelle, that's a great point because rehab tends to be just exceedingly fragmented in a lot of cases. And so a lot of times when we're working with members, if they have access to outpatient claims data, it's a great idea to get a sense of what's going on. And you probably will see some actors in the market that are seeing a lot of patients first that you didn't even know about. That's critical. And pretty much every state now has direct access to PT. So sometimes we'll encounter members where this isn't really possible. More and more, pretty much everywhere, that is something that they can do first.
In my personal experience, PTs are really good at knowing how to get through pay or prior auth, because I've just called them. They're like, do you have a referral? No. What hurts? Like my back and my knee. They're like, perfect. We got it.
Love it. Yeah.
Yeah, every couple of weeks, and they know how to do it. And why would I go to a surgeon or primary care first?
Right. And increasingly payers are going to stop you from doing that. So it makes a lot of sense. That's the other side. And part of the reason why we see rehab as increasingly being an important part of disease-focused programs, so that no matter where you are in your care journey, we're going to have the right piece of it for you. From that disease-focused program, this idea of a one-stop shop is one that we've heard of some programs really trying to do here, if you're able to take that approach. And this is where I think there's a good program example that we could talk about. I recently attended the NERVES annual meeting, which is the Professional Society for Neurosurgery Executives, and they have it every year in conjunction with the AANS meeting. And so this year at that, we took a tour of Northwestern Center for Spine Health that's in their downtown Chicago campus. And that really is meant to be the one-stop shop where if it's surgical, non-surgical, really everybody all sort of in the same space working together so that they can collaborate and build a unified experience around patients. Part of that is that they have rehab in this space. They've got a really nice facility in the center where there are beautiful views of the Chicago skyline. And in that, you can come and get your physical therapy weekly if you're a part of the center. And they have hundreds of visits every week for that. It's been critical for patients who they're going to have as part of their spine episode many physical therapy visits. And if they have it embedded in the center now, we don't have to worry about them bouncing around to multiple places the way they often have to. And sometimes sort of getting lost if things aren't going as planned. And physical therapy, I think, is one of the areas, particularly for spine musculoskeletal, where it can be a leaky point where, say, something's not going to plan, you're not getting the results you want. It can be where patients end up exiting your program. Having this embedded is an important part of the philosophy of having patients that have these multifaceted care plans. Make it as simple and cohesive for a patient as possible. And so having it embedded in those programs is a really, really great way to do that.
Kate, I think that leakage point is really important. And that's why we also talk to a lot of systems about having a cash-based pay model in addition to providing services for patients covered under a wide range of insurance plans. That cash-based payment can really let patients take control of their care. And often you can offer that cash payment at a very similar or even maybe less of a rate than their co-payment might have been. And so you can continue to give control of their care to patients. And maybe they want to see the physical therapist for a drop-in, like my knee hurts, or maybe they want to go to a couple more visits, or maybe they want to do their visits quicker than the insurance product is allowing them to do. That can be really important to keeping patients within your system or at that physical therapy provider that you have a partnership with.
Yeah. And if you think about someone who's having a surgery, they're probably meeting their deductible. So this probably matters less in that year. But again, most patients don't need surgery. So that's going to be a tremendously large population that you could be getting.
Donnelle and Kate, with how leaky this patient journey can be, and like you said, a lot of patients aren't even on a surgical pathway. There's so much joint venture and investor ownership in orthopedics groups. Does that also mean there's the same kind of investor ownership of PTs?
Kate and I actually got a sneak peek into some new disruptor data by Service Line the other day, which is really exciting. And there actually is a really high prevalence of rehab disruptors in orthopedics. We're going to dig into it more, but it looked like it might be the highest level of disruption in our service line. As we look at other things that are just entering the market that we see on a daily basis ourselves as healthcare consumers, organizations and offerings like Hinge Health that offer a virtual exercise program are also part of the conversation now. They might not be a full-blown physical therapy session, but they are a place where patients are getting access to this kind of care that are also out of our viewpoint because they're not claims-based. So this is a service offered through employers, or you can personally buy it, and that take that piece of care out of our traditional health system and out of our insurance environment and creates a little bit of a blind spot for us.
Yeah, that's an important one as you look at the fragmentation. It's going to be one that you can't necessarily see that could be a replacement for what would have been that feeder into your program. So I think that's an interesting one. But there are probably opportunities for us to use it too. I know we've seen some studies where with that kind of virtual exercise therapy, maybe in a fee-for-service environment, it hasn't taken off as much. But if you're thinking about employer relationships or bundled payment, this example came up for me again recently, Donnelle, as we were hearing about the proposed addition of a new program that would be mandatory bundled payment for a broader range of conditions besides just joints, the way that you've been seeing already. There's an opportunity for traditional health systems to partner up or maybe start to adopt some of those virtual rehab, exercise therapy types of platforms so that they can start to manage episode costs by either improving outcomes or reducing the cost associated with in-person visits. It could be a disruptor or it could be something that helps us get where we need to go.
I think it could be the impetus to getting some of those pre-surgical programs off the ground or the post-op, not synchronized exercise programs that some health systems have invested in, especially before there was any reimbursement for remote monitoring for physical therapy or in a rehab or orthopedic space. So it's not that we never saw that and health systems never invested in it, but here you have a lot of investment from private equity and venture capital in a space where we know does help patients. And this exercise therapy space, whether it's pre-op or post-op, it's exciting to think about how a health system might be able to leverage a partnership with them or use as an example of how to reach their patients.
Thanks. Good answer. At the beginning, we alluded to this is an area where there's pretty big growth. Donnelle, talk about some of what we're forecasting for growth. You probably mentioned it in one of the IOC focus episodes, but just revisit those numbers. And then I know there's some qualitative pieces here around barriers to that growth.
When we forecast rehab, we have different procedure groups. And for our evaluations in PT and OT, both in spine and orthopedics, we're projecting over 20% growth in the 10-year forecast, which is a lot. We anticipate a lot of evaluations, and that's really in line with what we are projecting from a surgical growth standpoint. Even if we see some trends that are dampening the use of PT, OT, or shortening the length of treatment cycles, we're still seeing a lot of evaluations for those post-surgical patients and pre-surgical patients to see when and if they should get surgery. And we're also seeing about a 10% increase in orthopedics for those follow-up PT therapies and OT therapies, the actual work of doing the therapy in that same 10-year timeline. A lot of opportunity here to capitalize on this growth, whether it's virtual or in-person visits for health systems.
From a qualitative perspective, there are a couple of pieces that we should probably acknowledge as well. And Trevor, going back to the beginning of our discussion when we were talking about the fact that physical therapy is sometimes a more flexible potential resource for us, the flip side of that is that sometimes that we hear in more rural or underserved communities that even though generally PT is a little bit easier for them, it's not, and there are some access restrictions. One that I know we've heard of from time to time is a little bit of controversy, particularly on the Medicare side around the rule basically that you need to have direct supervision for physical therapy and occupational therapy assistance. And that's been one where we've heard a little bit of discussion and controversy as well as some pushback about the payment differential for those things, given that there is the direct supervision requirement. And by the way, this is really a private practice specific issue that we're seeing right now. We've heard that there's been legislation introduced in the last year that's supposed to tackle some of that. Only time will tell what happens, but that is something to consider as a way, hopefully, that will open up a little bit of access and perhaps make some of the rules more similar across sites than what we see today. So those are just some of the issues that we're hearing that for some markets are still going to be barriers to being able to implement some of these things.
We already talked a little bit about employment and alignment trends in terms of other alternatives for PTs, but from a health system perspective, is this a nice to have piece or really a need to have piece of the ortho and spine system of care?
It is completely necessary for ortho and spine. We have seen through some of our consumer engagement and loyalty work that PT and OT channels can really be used to target high spending consumers. Besides the spend portion, it's really necessary and critical for that comprehensive care of patients, especially when we look at bundles. We have new proposed bundles for orthopedics, obviously not new. We all have a whiplash when it comes to bundles for total joint replacement, but also things like mandatory reported outcome measures. All of these things, in addition to things like access, make physical therapy, outpatient rehab programs very critical to the success of your overall orthopedics program. And if you layer on sports medicine into that, it's even more important.
in addition to just the fact that PT seems to make programs more cohesive, if you just look at the sheer volume as we look at what the whole world of services is for that musculoskeletal patient or that spine patient or that neuro patient, from a sheer volume perspective, if you don't have the rehab portion, you're missing most of it. So yes, I would say it's absolutely critical.
Kate, especially for those spine programs where about 85% of patients end up going through a physical therapy regimen.
Yeah, it's 85% of people that don't need, it's only that small portion of patients that ever need anything besides that. So yeah, very critical. It's funny that we push everybody towards rehab, even though the actual data on rehab, it's not proven as being something that's better than surgery or whatever. And it kind of matters who the patient is, but because it's less expensive, that's where everybody's going to be driven to begin with anyway. And we see that with the payer requirements, all of these things. They send them there, even though technically it's not really as well proven. It's because it's cheaper and patients do end up getting better. It's been really interesting to see how all of that happens. Whether you believe in it or not, you got to have it.
You have that 15-minute segment with them and you give them this book of exercises to do and send them away until the following week. And I do think that's where we can start leveraging things like sensorless tracking and wearables to accelerate or monitor, even at the very beginning, the actual efficacy of therapy and what patients really are doing at home.
Oh, I totally agree. That's going to be huge in neuro rehab because it's all about, okay, well, the patient says that they were active for half an hour. Were they really? Probably not. And then how will we ever know if they actually were? Even adhering to that treatment regimen, getting those less qualitative outcomes measures and ways of tracking what's actually being done. That's been a huge issue for even the research and the studying of physical therapy's efficacy, that exactly a lot of these technologies hopefully will help give us more objective measures of what was done and how well it worked.
There are some real opportunities for AI in this space too that are not out there yet. Don't anybody get too excited. We also can't even quantitatively measure something like balance. Balance evaluations are essentially subjective. They just watch patients walk and stand. So there's whispers of AI working on actually quantitatively measuring things like balance, which could lead us to be able to prove more significant outcomes with things like physical therapy.
I love it. That's awesome.
Donnelle and Kate, thanks so much for outlining this exciting, growing, but still pretty dynamic space. Always value your perspectives and look forward to hearing them again.
Thanks, Trevor.
Thank you.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and/or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.